I can just use myself as an example. So when I was in medical school, I had my son really early. I was only about 5.5 months pregnant. I didn't have the risk factors that people think of. I'm supposed to have good outcomes, and here I am having a baby in my 5th month. And so my only risk factor was being Black. When you look, despite income or education, Black women are more likely to die in childbirth, or more likely to have babies who have come too early. You can see that it's not anything genetically different or nothing about our biology, but how we're treated, how we're seen, how we're valued, right? So that's whole idea around women and not having bodily autonomy. When you add on also racism, so gender oppression plus racism, you get the outcomes and the differences we see. You can't just change policy. We learn from the civil rights movement. Until we hold people accountable for discrimination or hold them accountable for their bias, they're going to still keep having those behaviors.
The 2030 Agenda for Sustainable Development is grounded in respect for human rights and the power of people to change the world. Every individual on the planet has the right to health and well-being in all aspects of their sexuality, their body, and their reproductive choices. Ensuring these rights is integral to addressing poverty, education, violence against women, and gender equality. Sexual and reproductive health rights are agreed in international law. They were fought for by courageous women's rights activists and advocates across a broad range of professional fields and frontline experiences by movements of all ages, levels, and backgrounds. They are still being fought for. While progress has been made globally, many barriers remain, especially for those most marginalized, excluded, or discriminated against. Human rights are central to delivering the 17 Sustainable Development Goals in the Sustainable Development Agenda. Indeed, each SDG target is simultaneously a metric and a claim for human rights. The interplay between these political commitments and human rights obligations is particularly important when it comes to achieving sexual and reproductive health rights. For decades, human rights-based tactics have been used to drive progress. In this episode of Right to a Better World, experts share challenges they have faced and tactics they have used to address them. The challenges they describe occur in settings all around the world. The strategies used are ones that they have found to be successful in their own settings. Viewers are encouraged to learn from these experiences and consider how tactics could be adapted to their own contexts. When sexual and reproductive health begins with equality, the discussions, decisions, programs, and policies which follow can build towards a future where every individual is not only born free, but lives free and equal in dignity and rights without violence or discrimination. The time to take action is now. The 5 leading causes of maternal mortality are severe bleeding, infections, high blood pressure, complications from delivery, and unsafe abortion. Although most maternal deaths are preventable with well-known healthcare solutions, an estimated 295,000 women die in childbirth or from pregnancy-related causes every year. For girls aged 15 to 19, pregnancy and childbirth complications are the leading cause of death. 45% of abortions are not performed safely, causing up to 13% of maternal deaths. 94% of maternal deaths happen in low and lower middle income countries. Millions more survive with the punishing physical and psychological injury of pregnancy complications. Maternal mortality is often a result of systematic violations of key human rights principles such as accountability, equality, non-discrimination, and meaningful participation. Maternal health outcomes have improved globally over the last 2 decades, but not far or fast enough. The commitment in the SDGs to reduce preventable maternal mortality is recognition that more efforts are urgently needed. Actions must be linked to human rights imperatives and to the promise of the SDGs to leave no one behind. There are many factors preventing women from receiving or seeking care during pregnancy and childbirth.
The issue is generally equipping the hospitals and making sure that whatever that pregnant woman is can be identified and can reach where they can get help, okay? And then the people giving that help have the skills and the equipment to do it.
There's also a big divide between urban spaces and rural territories where most of the indigenous people and particularly women live, and they live in completely different universes than women in cities do. Women have not been able to reach a certain hospital during an emergency because they are living in a remote place, and this entails a 10-hour drive.
Gender biases linked to power, resources, norms and values can limit the position of women and girls in society and take a damaging toll on their health.
In many situations, women are not able to make a decision on their own. They have to seek permission. A younger boy may decide for an adult woman whether she needs to go to the hospital with an obstructed labor or not. How do we educate the communities to make them know that, yes, these women's lives are important to save?
Every year, at least 12 million girls are married before they reach the age of 18. Early and frequent pregnancy often follows, resulting in higher than average maternal morbidity and mortality rates. Additionally, a growing body of evidence shows that women are being mistreated during childbirth in health facilities across the world. This includes physical and verbal abuse, stigma and discrimination, neglect and unconsented procedures such as cesarean sections, vaginal exams, and episiotomies.
There is a kind of disrespect and abuse that's become entirely normalized amongst those providing childbirth care. And this is often not talked about, but it's very visible, especially for poor women or women from, in India, the lower castes.
Almost half of all pregnancies, 121 million every year, are unintended. Women and adolescents seeking an abortion often resort to unsafe abortion when they cannot access safe abortion, regardless of income or legal restrictions. The complications can be life-threatening.
Women in Mexico are struggling to access abortion in situations where their life may be at risk. And this is going to be very important for maternal mortality as well, as abortion in Mexico continues to be the fourth cause of maternal mortality in the country.
We already have a public health sector that's unwilling to provide safe abortions. So we have many women and girls who don't have the resources being pushed into unsafe abortions.
Doctors object not only to performing services, but also to refer a woman when she could get services to which she's entitled to. So the rights of doctors, according to the Polish Constitutional Court, are superior to women's right to services.
A woman's lifetime risk of maternal death often depends on political, economic, social, and cultural dimensions beyond her immediate control. Context, gender, race, social position, age, disability status, sexual orientation, ethnicity, religion, employment status, geography, and citizenship.
Yes, it has gone down, but it hasn't gone down for all types of women. So we still have very, very significant differences. If you are an indigenous woman or a woman living with a disability or a young pregnant woman, from being a woman that is more privileged and lives in the city and is non-indigenous.
The whole idea around who's in control of who can have what exist everywhere, even in more liberal spaces. Despite income or education, Black women were 4 times more likely to die in childbirth in the United States than their white counterparts.
Over the last few years, activists, healthcare providers, and policymakers have managed a strategic shift, moving maternal mortality and morbidity from a medical issue to a challenge of human rights. This approach puts women and girls at the center. Accurate measurement of maternal mortality is essential to monitor progress, including towards the SDG target indicators. Many deaths around the world are often misclassified or go uncounted.
You must first identify the main cause of your maternal mortality. So then based on your root cause analysis of what is causing your mortality, then it's easy to put mitigations on what will address that specific cause.
So we're working to invest in the city having just a statistician around maternal deaths for the city. And so they agreed to do that. So that's a huge win. It sounds small, but it's important. If nobody's counting, then you don't exactly know what's happening, where people are, what's going on.
We had to get the science and the research right. So we needed to bring the evidence in order to prove that abortion was necessary for public health reasons. So in other words, it was necessary to save women's lives and to save women's health.
Healthcare systems are stronger when they are structured around the needs and values of the individuals they care for, with enough resources and finances.
A very important specific aspect that has been treated by different groups and by the government is around referrals and knowing and to identify situations of emergency that do merit maybe a more specialized care and hospital. And in this sense, something that has been very interesting in Mexico has been to recognize the value of traditional midwives that work in communities and to give midwives sufficient tools to know when to refer women to other types of services and how to treat just normal pregnancies, which has a very important effect, not only in maternal mortality specifically, but also in much more culturally appropriate services. And these traditional midwives do have the trust of the community. They know women from many, many years ago. They speak the same language. They know the family. They have a different type of knowledge.
Then the health workers now in the level 1 and level 2 now can facilitate the next transfer to the next level by identifying the risk factors, and then mitigation can be done. So all this needs money. Lobbying the members of parliament, the rights people, everybody trying to make sure that the voices are heard, that when the budget is being done, the health is given a priority.
All women have a right to a positive childbirth experience. Addressing systematic challenges at both the health facility and health system levels is essential for reducing mistreatment during childbirth and delivery.
The type of situations involved in obstetric violence can be very ambiguous or very varied. And most of the times they're due to very systemic circumstances related to budget allocation, to infrastructure, to medical education in general. One of the main challenges that we have faced on this issue has been the tendency, at least in Mexico, to try to resort to punitive measures when speaking about violence. Sometimes speaking about this as a type of violence leads to resorting exclusively to criminal law. It does alienate health professionals from the discussion.
Some facilities are trying to have places which can help the nurses, counsel them, when they are burnout, and also just employing more health workers, motivating them might reduce the burnout. But again, if you have a working referral system, might also reduce the violence we see at the facilities against women coming to deliver, pregnant women.
Making sure that the healthcare providers have access to current tools and training that support their provision of rights-based care is critical.
Health professionals might not be aware of certain guidelines from WHO, for example, or they might not be aware, or they might be wary about what their obligations are. So in the case of abortion, the clarification of what the responsibilities are when a woman or a girl arrives at a clinic with an obstetric emergency has been very, very important to be able to respond immediately to these types of cases.
The health activists worked a lot with midwives and nurses on programs called values clarification, which were to try and get midwives and health workers to understand why women's right to choose was important. And it was very successful in the first 5 years or so. The research that was done showed that maternal mortality and morbidity reduced drastically.
Litigation is an important pathway for changing laws that directly inform national policies and plans.
Working in the courts allow for incremental improvements. It is slow, but from the other side, it remains.
A very important case in Mexico was a case of a woman that was pregnant, and then during her pregnancy she realized that her health was at risk. She tried to access the service and she was denied this, and it went to different instances until it reached the Supreme Court. And what the court ruled, which I think will become very important in the future in Mexico for the human rights discussion, particularly related to reproductive rights, was that access to abortion in cases of health risks was part of the human right to health, which is protected in our Constitution.
International human rights mechanisms, such as the Human Rights Committee and the Committee on the Elimination of Discrimination Against Women, CEDAW, can be used to hold countries accountable when national mechanisms fail. The case of Aline da Silva Pimentel versus Brazil, decided by CEDAW in 2011, established an important precedent for the human rights-based approach to maternal health.
The CEDAW committee handed in this decision, which for the first time recognized maternal mortality as a human rights issue. And it also recognized that this was a violation of women's right to equality. So this was really mind-blowing at that point, because it changed the landscape. I think that women understanding that maternal care and quality of care is a right can be huge. It has a huge potential, because it's a starting point for women demanding and saying, okay, this is not normal. I should not be subject to this kind of treatment. I have the right to. Demanding is a starting point to changing many things, and it starts with knowing what's the right that you have.
So increasingly health workers don't talk about conscientious objection, they talk about barriers to access. And it's a conscious attempt to shift the language, is to say this is not about the thinking of the individual health worker, it's about access for the woman. So let's call it what it is. It's a barrier to women's access. And how do we treat a barrier to access? And I think it's a wonderful political shift.
Delivering on the promise of the SDGs, as well as human rights obligations, can only be achieved through active engagement with communities. Communities are ideally placed to support women to go through pregnancy and childbirth safely, with all their human rights upheld.
So we try to empower the communities, but through education, through taking ownership of the programs, through taking leadership in the healthcare system within their environment.
So what communities did was to push for a program that would really encourage mothers to deliver in the hospitals. This was an advocacy that was led by women themselves and people in the county. They even did budget proposals, they did memorandums to the county. Our work is simply to give them direction, not necessarily tell them to do this, but just to direct them and technically guide them.
Strengthening women's and communities' voices can further strengthen the health system's support for women, newborns, and families.
In the beginning, very few people had an understanding of human rights dimensions of reproductive rights, of women's rights. But this educational process led to those vast protests in the streets now, because those women who went in the streets, they are very well aware of their rights, of what they expect from the government.
We've tried very hard to ensure a shift in the power relations. So women have been organized into collectives. They are informed about what are the standards of care, for example, in pregnancy checkups, in childbirth services, in postpartum or abortion care. And being informed, they're actually able to negotiate with the providers, demanding. We do need to empower the users of services, in this case the rights holders, with complete information about their entitlements and about the standards of quality that they should be expecting in public services.
Maternal health is a core component of sexual and reproductive health and rights, and reducing maternal mortality and morbidity is fundamentally a matter of human rights and a globally agreed commitment under the SDGs. A human rights approach is more than theoretical. Human rights-based tactics can offer a practical route to addressing systemic challenges such as barriers to accessing quality care, gender bias and power structures, legal restrictions to women's autonomy, and discrimination against marginalized groups. By building the evidence, strengthening health systems, delivering rights-based education, bringing strategic litigation, reframing the issue, engaging communities, and empowering rights holders, every individual can help to deliver the 2030 Agenda for Sustainable Development, ensuring every woman and adolescent's right to not only survive pregnancy and childbirth, but have a positive experience of this profound life event.